Neuropathic pain, often abbreviated as NP, is a chronic and disabling condition that arises from a lesion or disease affecting the somatosensory nervous system. Unlike typical pain, which serves as a warning signal for potential harm, neuropathic pain is persistent and can be difficult to manage. It is characterized by a systemic inflammatory state, and its symptoms are often underrecognized, leading to challenges in diagnosis and treatment. Patients may experience sensations like burning, tingling, or numbness, which can significantly impact their quality of life. Understanding the underlying mechanisms of NP is crucial for effective management, especially since standard painkillers often provide little relief. Neuropathic pain can be classified based on its origin, central or peripheral. Central NP is linked to conditions like spinal cord injury, brain injury, or multiple sclerosis, while peripheral NP often results from nerve injuries, diabetes, infections like HIV, or chemotherapy. NP affects about 7–10% of the global population, with a higher prevalence in women and those over 50. The pain can be persistent or intermittent, and is often accompanied by emotional and psychological symptoms such as anxiety and depression. Recognizing the diverse causes and presentations of NP is essential for tailoring appropriate treatment strategies. Patients with neuropathic pain often report a range of symptoms, from positive sensations like tingling and heightened sensitivity to negative symptoms such as numbness or sensory loss. The pain may be described as shooting, burning, or aching. Diagnosing NP requires a thorough medical history, physical examination, and sometimes specialized tests like quantitative sensory testing or nerve conduction study. Questionnaires such as the Leeds Assessment of Neuropathic Symptoms and Signs, LANSS, or Pain Detect help clinicians assess the subjective experience of pain and its impact on daily life. Accurate diagnosis is vital to avoid mismanagement and to guide effective therapy. Development of neuropathic pain involves complex changes in both the peripheral and central nervous systems. After nerve injury, immune cells like Schwann cells, mast cells, and macrophages respond by releasing inflammatory mediators. These substances sensitize nerve endings, leading to pain. Over time, immune cells infiltrate the central nervous system, disrupting normal function and contributing to persistent pain. Glial cells, once thought to only support neurons, are now recognized as key players in maintaining chronic pain through neuroinflammation. Understanding these processes highlights why NP is so challenging to treat and why inflammation is a central target for therapy. Managing neuropathic pain requires a multifaceted approach. First-line treatments include tricyclic antidepressants, selective serotonin and norepinephrine reuptake inhibitors, SSNRIs, pregabalin, and gabapentin. Topical therapies like lidocaine and capsaicin patches are also used, especially for localized pain. Sometimes, a combination of medications is necessary to achieve better pain control and minimize side effects. Non-pharmacological therapies such as physical therapy, cognitive behavioral therapy, and even electrical neuromodulation can be valuable additions. The choice of treatment depends on the underlying cause, patient comorbidities, and potential side effects. Antidepressant drugs are not only used for mood disorders, but are also first-line agents in neuropathic pain management. Their analgesic effects appear within days, while antidepressant effects take longer. These drugs increase levels of norepinephrine and serotonin at the spinal cord, enhancing the body's natural pain-inhibiting pathways. They also block sodium channels, reducing abnormal nerve firing, and modulate various receptors and ion channels involved in pain transmission. Tricyclic antidepressants like amitriptyline and nortriptyline act on multiple targets, making them particularly effective for NP, though side effects must be managed carefully. Recent research has revealed that antidepressants also have anti-inflammatory effects, which are crucial in neuropathic pain. For example, amitriptyline reduces the expression of pro-inflammatory cytokines by acting as an adenosine agonist and activating the A3AR receptor. Nortriptyline, on the other hand, inhibits the local production of TNF-alpha, a key driver of neuroinflammation, by acting on beta-2 adrenoreceptors in satellite cells. These actions help reduce pain symptoms and may prevent the progression to chronic pain. This dual effect, modulating neurotransmitters and inflammation, explains why antidepressants are so effective in NP. Studies in animal models and cell cultures have shown that antidepressants can suppress the overproduction of inflammatory cytokines like TNF-alpha and IL-1 beta, which are central to the development and maintenance of neuropathic pain. For instance, amitriptyline has been found to inhibit pathways that lead to inflammation and neuronal sensitization, while nortriptyline reduces allodynia by modulating norepinephrine in the dorsal root ganglia. These findings support the clinical use of antidepressants for NP and highlight the importance of targeting neuroinflammation in pain management. Neuropathic pain remains a challenging condition to diagnose and treat, but advances in understanding its mechanisms are opening new doors. Antidepressants play a vital role not just in symptom relief, but also in modulating the underlying neuroinflammation. Ongoing research aims to further clarify how these drugs interact with inflammatory pathways and to develop even more targeted therapies. Ultimately, a deeper understanding of the interplay between the nervous and immune systems will help improve the quality of life for patients suffering from neuropathic pain.